Good morning, people. Welcome to Coffee Chat. We can talk a bit about NeuroCentric approach today if anybody wants to come on. Those of you that are on the Zoom meeting, we're waiting a moment for folks to wake up and get their coffee poured and come join me. It's a beautiful day outside here in Portland. We have pretty much idyllic fall weather, although a little bit warmer than usual. I've seen some of you guys down in California dealing with 100-degree temperatures right now. That's a bit different. I guess El Nino is going to make you guys warmer and us cooler this year for the winter. So I'm going to hold out here and wait for a few folks to join. In the meantime, you guys can go get yourself a cup of coffee and settle in. So, those of you that are joining in, got a special guest today. My son has joined us this weekend. Good morning, Dr. Dingser, I assume. Is that you, Brian? Yes, it is. Hi there, bud. Morning, Brian.
Hey, good morning.
You are, what are you in? You in the basement escaping your family?
Yeah, I got one little guy with me though.
Oh, that little guy. I remember seeing him last time.
Yeah.
And hey, Justin, good to see you too, bud. So, did either of you guys check out the new course that I put up last week, the sports hernia?
I haven't had any time yet. I've been still catching up on things.
Say that again, Justin.
Not yet. I was excited to look at it because I have my first sports hernia case. If you'll have to bear with me. I've got a screaming kid in the background, so I'll be muting a lot of it. But
yeah,
I have my
too.
first. Yeah.
I'll scream on cue if you want.
So no, I haven't had a chance yet, but that's first up to see what you had, and then compared to my first sports hernia case where I gave it a shot. And
cool.
Like, okay, let's see how it goes.
Yeah, I mean, consistently, it looks like what I'm seeing for most of the people that are playing with it and are reporting back. I think a lot of it is a lot of folks are still kind of caught up in the DTM romance. That it's really instinctive for folks to lead with something that might be able to take away pain that quickly and turn a patient's head and make them think that you know something different than the other people that they've seen. And I'll admit that I'm guilty of it as well sometimes. And the places that I see that it really comes back up, and I notice that I've been a little bit slack in my work there, is the symptoms keep coming back pretty regularly. So you're able in one visit to do some work targeting a peripheral interface, most commonly something superficial cutaneous. And the patient feels better. And yes, they do that at home and they still feel a little bit better, but you keep needing to see them because something, from what has been my experience, upstream, further up that neural pathway has not been explored in with due diligence to try to take the thing that's sensitizing that neural pathway off of the table a little bit better. So I always think about it almost from an algebraic perspective, that we've got, a summation of the interface points. Get all Pythagorean on it and say it's a squared plus b squared is equal to c squared or something of that sort. And the a in this case would be the interface at spinal cord, nerve root, IVF. The B might be the larger caliber mixed peripheral neurology. And the C might be the smaller caliber superficial cutaneous neurology. And of course, back there in the background, what's D and E are the pain science aspects and the systemic health, metabolic health kind of aspects as well. And candidly, as all of you know, those are less common or even more difficult conversations to try to have with a patient, because they typically mean a pretty solid change in perspective. If you're dealing with pain science stuff, a pretty solid change in the person's perspective of what's going on in their body. And sometimes changing minds is a bit challenging, as you guys have experienced, I'm sure. And the other aspect is changing lifestyle. And that people don't want to change lifestyle. They just want you to fix something. So yeah, that's been an issue on the Fix Your Own Back platform as well. Trying to find product market fit on that, and we relaunched that a while back and put a marketing plan in place and had a team working that. We were able to easily get people into the marketing funnel that we were bringing them in like gangbusters, but everybody we got was poorly qualified. They were literally, I was talking to people on the phone, they were 350 pounds. They haven't gotten out of bed in 3 days. They've had 3 surgeries and they're diabetic, and they don't have any motivation to make a change. They're like, what can you do to help me? Like, through a computer, and you not being willing to get up and out of bed or change the way that you're eating. Not a whole hell of a lot. So let's see. Guillermo is joining us as well. Hey, Guillermo. Good morning and welcome. Hey, Guillermo, I got a surprise for you.
What is it?
I think one of the last times I saw you personally might have been around a campfire on Orcas Island.
Gosh, that was a while back. No, remember we ran into each other in Seattle like 5 years later? We're like,
yeah, that's right. My wife and I were doing a staycation up there.
Yeah, but, how is she, by the way?
Paula's doing well. She left yesterday to go on an adventure.
Nice.
She is hiking Hadrian's Wall by herself across Britain from west to east. So she managed to get a continuing education junket through Kaiser, where she works. So they paid for her flight over and a couple of nights stay, and she books her CE, and they pay for her CE. So she's going over for 2 weeks to walk the wall, and then to go to Birmingham and sit and take a course in, I think this one's in trauma management. But
Wow.
she's doing well. But what I was leading into, the surprise, do you recall around that Orcas Island campfire at I think it was Cascade Lake? I might have had a little guy with us.
Yeah. Oh my God.
Probably not so little. I don't remember this at all.
Of course you don't.
I don't know how little you're talking here.
Yeah, this would have been Galen would have been like maybe 4 or 5
Okay, yeah.
at that time. Yeah.
Wow.
You're what, 28 now?
Yeah, that's about right.
Yeah.
Wow.
Only 24 years. So.
Yeah.
Well, good to see you again. I can't
Yeah,
remember the last time, but good to see you again.
yeah, my son is 27 and he was there too. I don't know if you recall.
Right
oh,
on,
wow. Okay,
right on.
cool. That's really
Yeah,
Yeah, I think these
Crazy.
guys might have actually played
cool.
together
We
a little
probably
bit.
did, yeah.
Yeah.
they did. Yeah, that's crazy, man. How time flies.
Yeah, it does. It's true.
Yeah, he's a full bore Canadian citizen now as of 2 weeks ago.
It's true. It's true.
Good call, man.
Thanks. I thought the same thing.
Well done, my friend. Well done.
Yeah.
God,
So,
that's crazy.
So Guillermo, we were just chatting before you came in about the sports hernia course. Did you get a chance to check that out?
No,
Which
I've been
courses
in
have you done? Which courses have you played with so far?
actually haven't. I've been in Miami the last 2 weeks. The week before
Oh.
that. So the last 3 weeks it's coming back and forth in Miami and here because my wife's father, my father-in-law passed away.
Oh,
So
I'm sorry, Guillermo.
oh, it was actually it was a good thing. He was not doing well. So it was expected, you know. So, uh, he was suffering, so it was a relief to the family, you know.
Let's see.
But yeah, it still hits
Yeah.
you, right? Um,
Yeah.
so she went to Miami, and then I went the following week because we're more worried about her mother, right? They've been married
Yeah.
since they were 17, and he was 91.
Wow.
Yeah.
Wow.
So she's actually going back in November, and 3 weeks from now, she's gonna go stay 2 weeks. Yeah. So yeah, I just been going back and forth a lot.
Yeah. Well, my heart goes out to you, mate. 91 is a good run.
Mhm.
Hopefully the last several years weren't totally spent in the state you're talking about of suffering.
It was I would say the last 9 months, just, bedridden, not great. So
Yeah. Yeah.
you can imagine the mother, the wife, like how stressful that was. So yeah, so the family is somewhat relieved. So we're actually worried that she was gonna, something was gonna happen to her. She was still stuff. She's perfect.
Yeah, the drain on the other party in a relationship like that, especially if the end times for the person that's checking out is due to some sort of dementia, that's brutal. It's one that we saw in our family as well when my dad passed, and he was suffering cognitively for a good 5 years, and yeah, it destroyed the family financially, destroyed the emotionally. We're all estranged from each other as a result of that now, and yeah, it's brutal. It's a tough time. So, virtual hugs out to you, my friend.
Yeah. Sorry to hear about your family. Can't believe that.
Yeah. Now, shifting to more favorable topics at hand. I'm not going to take a beautiful sunny Saturday and cast too many clouds on the horizon here. Brian, talk to me about your experience playing with this stuff. We've been back and forth several times on the community forum about different patients, and I'd love to hear any questions that you got or any thoughts that you got as you play with the material and with your patients there in South Dakota.
Yeah, was it last week or 2 weeks ago? I think it's 2 weeks ago with that weightlifter. You covered his shoulder arm pain, and then that interface where the radial nerve goes between the intermuscular septum and the arm. And what's crazy is you start looking for it, and like 3-4 different patients had a problem there. Had a volleyball player, teenage girl, had elbow pain, couldn't serve, and so she couldn't fully extend her arm. So that was kind of her test in the office, is she had pain even just with full extension or just going overhead with her arm. I just did DTM over the area and took away the pain completely. Now, I haven't seen her yet for follow-up because she was also dealing with some rib pain that was constant, and especially at night, and I'm worried she has a gallbladder issue. So she may
So
not
where was the rib pain?
just right on the front of her, right by the liver there. And it's pretty constant. It didn't get provoked at all with movement or anything like that. I said, just see your primary doc and get a liver ultrasound or CT scan. But because she had her appendix out 6 months ago and it abscessed, and they had to go back in and clean out that abscess.
I see.
So I'm just worried.
There is a deeper history there too.
Yeah, I'm just worried there's something else still going on in there. I'm like, that takes precedence. Let's worry about that first. And then
good that you're ruling it out, and certainly probably first line they would run a liver panel and see if we've got any elevated or
enzymes. Yeah. No, so sorry if that brightened up back there, but
fine.
So she was one case. Another case was a big burly landscaper who does a lot of concrete work. Same area. He could feel it when he raised his arm to shovel sand or anything. Hey guys, no ping pong. And same problem right in that interface area. Cleaned that up. Also cleaned it up in the axillary space, and 2-3 treatments, it's gone. So just kind of looking at that neural perspective is huge. Another gal she had shoulder surgery. She's gone to PT for 12 weeks post-surgery for a rotator cuff repair, and she couldn't. And we would see this a lot, but there again, it's like she had pain going here, but full extension, not as much.
Yeah.
Same thing, cleaned out the suprascapular nerve here, and then I cleaned out down through the tricep again, and then she's like, oh my goodness, she could go all the way. So
yeah, those are the good ones for sure. I've got one right now that is a bit irritating in that regard. The shoulders, my experience is that usually, unless it's a frank acute injury from some sort of mechanical stress, that the shoulders commonly there's a long baseline of some sort of radiculitis that's going on there. And in that shoulder course you mentioned, you might notice I really tried to hammer home that shoulders are very commonly a combo platter. You'll get at the earliest stage, I think, if we try to analyze how the dominoes line up, often there's some sort of a radicular component that's been underexplored, and then coming off of the C6 and C7 nerve root, we'll get 4 nerves primarily that wind up showing up. One helps to explain the McKenzie joint derangement pattern, where they would move away from doing any kind of extension if you get any kind of referred pain down along the medial border of the scapula. And in this case, that often, I think that pain in that area with flexion or extension is often related to a dorsal scapular nerve that's a bit unhappy. As owing to the motor innervation of the dorsal scapular nerve, they probably also have a winging medial border of the scapula on that shoulder. And owing to the innervation of the suprascapular nerve for motor for the supraspinatus and infraspinatus, we could have a little bit of altered motor function of those rotator cuff muscles as well. All of that leading to a bit of a changed loading pattern on the shoulder. They'll have a little bit more hiking to try to unload that neurology. And that alters the joint mechanics and physically narrows the subacromial space. And now you've got all you need to add to that is increased overhead movement in their life. So we'll see it, putting up Christmas lights, cleaning gutters, pruning trees at the end of the summer, this time of year. We'll see it in January, February, and March when people start a new workout program in the gym after their New Year's resolutions. And we'll see it after a change in a training block for an athlete when they're doing more overhead pressing and overhead pulling and that kind of stuff. So, I've got a bugger of a patient right now that she's a really hardcore former CrossFitter, competitive Olympic lifter, moved over to a powerlifting kind of format. And she works out at Kabuki with us. And she moved from her standard powerlifting workout with her 3 major lifts that she's been doing and started training more overhead with snatches and clean and jerks because she signed up for a competition that was, I forget what they call it, but it's some sort of overall strength competition where they do the 3 powerlifting lifts, a back squat, bench press, and a deadlift, but they also do a clean and jerk and an overhead snatch, and then you get a cumulative total on all of those. And she came in with 8 out of 10 pain in her shoulder anytime she tried to rack the bar for a bench press or rack the bar for clean and jerk. So in a front catch position or in a high bar back squat position, she had 8 out of 10 pain here. And she was just about in tears trying to set up in those positions, tough as nails. She would move through anything. And she just wanted me to get her through the competition. We were able to get her through the competition, and she felt a bit better. And then she rested, completely stopped lifting for about 3 weeks. And we had worked into, had very quick change working through her neck, then had a little more change working through the periphery on the targeted neural structures. But she had some low-grade adhesive capsulitis that was setting up, and starting to work into that when she competed, and she was moving better at the glenohumeral joint, but then she sat still basically for 3 weeks and didn't move the shoulder a whole lot, and it tightened right up after that. And by the time I saw her again, she comes in and she's like, my shoulder's back to where it was. And sure was. The adhesive capsule, or the adhesions on the capsule, were much worse. I couldn't make any difference working through the neck anymore. I couldn't make any difference working the peripheral neurology. I'm like, well, it's time to get a little help on this. So I sent her to a pain intervention clinic that I'd had good results with in the past for a capsular distension. Best evidence that I'm aware of, a relatively simple procedure. You get somebody to blow up the capsule with some some normotonic saline, and I sent her out to that office, and she got punted from the doc that I traditionally would have referred to a newer doc, an MD, sports med guy, who's really hot to trot. And even on the website, in retrospect, I look at it and says his favorite new treatment, extracorporeal shockwave therapy. So, Brian, that was some of the cynicism that you were getting from me and our replies back and forth on the community forum were exactly coming out of this. So this guy ordered an MRI, and on the MRI, it showed some pretty significant degenerative changes in the rotator cuff tendons. And he treated her using the MRI as justification for PRP injections over those tendons and follow-up extracorporeal shockwave therapy. And I'm like, so we do a PRP to ostensibly cause localized inflammation and stimulate an inflammatory process again. And then you do extracorporeal shockwave therapy to kind of do the same thing and to break up some localized adhesions. And the treatment plan was, one, not what I sent her over to hoping to get, two, which is, by the way, a cheap intervention and often a one and done kind of intervention. And instead she was, her treatment plan that she was offered was, we're going to do PRP injections twice to the tune, I think, of about $600 a pop, not covered by insurance, and follow-up recommendation of extracorporeal shockwave therapy twice weekly for 6 weeks at $300 a pop. And, you know, when this came across,
by insurance.
What's that, Gamero?
Not covered by insurance also.
Exactly. So now she's, I'm like, well, what am I going to do? I'm going to badmouth my colleague, or do I step back and say, okay, Jesus, take the wheel, So I gave him I talked with her about what I thought, and she was like, well, let's give it a shot. And literally, she got the shot, and adhesive capsulitis. She was, remarkably painful, worst pain that she'd had in this case yet. For a solid 3 weeks, she could barely move her arm. During that lack of moving the arm, she tightened up even more. So now she's 2 months out. She's several $1,000s paid, and she's just now getting back to the point that she was at when I referred her out. And she and her capsular adhesions are just as bad. And now, and I'm still struggling to get movement beyond those adhesions. And now the MD is saying, well, maybe we can do what Dr. Snell was talking about when he sent you over here. So she gets that referral or that follow-up this week, and we'll see if they actually do the capsular distension. Have you guys had any patients that you've gotten that for these kinds of issues? Eric, I see you over there lurking. Welcome in, bud. Feel free to weigh in on this. Have any of you gotten these capsular distensions?
I was going to ask is, how much is that procedure? I've never referred out for it before.
My understanding is it's covered by most insurances.
What does it entail?
Take a good size needle and syringe full of normotonic saline. Do a capsular injection with the idea of blowing up the capsule physically to release adhesions within the capsule.
Is that done
There,
typically by anesthesiologist or ortho or?
yeah, yep, all of the above. All of those are possible possible avenues there. Pain interventionists, physiatry, orthopedists, anesthesiologists, etc. You know, there was a real nice paper that came out on this early in the summer that I remember reading, and that was like it when it showed that, I saw it as being the very next bridge step for these types of patients to try to give them an option. You know, once we run into these capsular adhesion issues and you've cleared the neural aspects and you're still working the manual stuff, and you know, I'm game for trying extracorporeal shockwave therapy in those situations, but pairing it again with the PRP and using it as frontline. I do the distensions first, but what the hell do I know? I'm just a chiro.
Well, looking at that paper you sent out with the shockwave therapy, it depends on the machine they're using. Like you said, if they're ineffective or the wrong type of shockwave, you don't know what kind of results you're going to get. But looking at it from the aspect of if you can basically destroy those free nerve endings that grow into the capsule or into a joint or whatever, and basically desensitize that tissue so then the patient feels like they can move better, then the shockwave might be a good avenue. You know what
Yeah,
I'm saying?
yeah,
So,
I agree. I agree, and you know, the the research is kind of hit or miss on that. I think it probably has to do with the inclusion criteria and those particular papers, and you know, how these patients are chosen probably is going to make a big difference. And you know, an issue with that, which you just alluded to, Brian, as well, that I think is worthy of all of us keeping a closer eye on, and that's part of what I'm trying to include with this whole NCA thing, is you just described in the capsule the free nerve ending ingrowth from sensory nerves nearby that we're trying to change with extracorporeal shockwave therapy. And similar issues of ingrowth of nerve buds from sensory nerves in a tendon in places that nerves typically don't reside. And we see that in uh, uh, tendinopathies. And we try to, you know, put eccentric or slow loading in those tendons to try to change that local landscape and cause an outgrowth of those nerves. There's probably to my mind a mechanical transduction signal that's going on there, of loading the tendon in any way, in a load pattern that's slow enough to stay within the mechanical capacity of the tendon in its current degenerated state, but enough to cause likely a mechanical signaling process that we don't know about yet that causes the nerves to grow out. Because as you guys know, in a tendinopathy, or in a tendonitis, in a normal healing process of a tendon, you have an injury to the tendon, and exceeding the mechanical constraints of the tendon. And the neurology, the sensory and sympathetic neurons exist in the tenosynovial sheath, and they grow into the injured area of the tendon. And by design, after a couple of weeks period of time, they tend to withdraw. They grow. They retreat from that tissue. And a third area that we see this is in the annulus of an injured lumbar disc, where we have tissue compromise, some sort of collagenous tissue compromise. And then we have an ingrowth of nerves and blood vessels into tissue that typically does not house a lot of blood vessels and nerves. And then in the case of the disc, the thing that's been identified that causes the retraction or the outgrowth of that neurovascular tissue is the hydrostatic pressure within the disc. So if the disc is very floppy and you can't generate hydrostatic pressure, then the nerves keep growing further in, and now it takes less stimulus mechanically to make those nerves ping. But again, loading and what I've consistently found over the years that will tend to make those discs stronger is well-designed lifting well, lifting somewhat heavy, not too heavy, not beyond the mechanical constraints of the tissue, and then working a good pattern of lifting that has mostly on a deadlift loading kind of pattern, a compressive load that's not putting a tensile load too much with some flexion in there on the disc. And that tends to work well. People, disc gets stronger, bone gets stronger, joint gets stronger. The aspects of pain neuroscience and agency begins to change, and all of that gets better. So that's all the integrated aspect. And then just like to bring it back around to the systemic issue, in all three of those cases, joint capsule, disc, and tendon with these injuries, in all three of those cases, there's been a positive association in the literature of an increase in prevalence of all three of those conditions in patients that have metabolic dysfunction of some sort, obesity, hypercholesterolemia, and any kind of metabolic dysfunction that looks like insulin insensitivity and blood sugar control and things of that sort. So I think I think what I've got going on here with this particular system, this epistemology, if you will, is something that kind of brings together those three aspects of treatment: pain science, systemic health, and peripheral neurology and its affected status when some of these things are not being tended to. So I'm bullish about the future with this. I just need to get the word out there a little bit more.
So I know Justin Dean really focuses on this, but with let's say a radicular issue coming from the neck, I've noticed he really focuses a lot on if a nerve is tethered further downstream, even into the hand. I'm more of an insurance-based practice, so time is an issue. So I find it hard to take the time to kind of check the whole path of the nerve. I mean, how do you become more efficient? Are you finding it more via, your nerve tension test, like the upper limb nerve tension test? I know sometimes, do you go by like if they say they extend their limb, if they say they feel the tension here, do you go right there, or how do you know if it's below or above, or what? How are you kind of figuring that out?
That's the graded neuro aspect that graded nerve, the GNE, graded nerve evaluation that I'm trying to promote I find that immediately when they say it hurts right there, I want to go there so bad. I want to reach right there, and it's like my wife gets pissed off at me about this because she'll have a hurt area and she mentions it. And just unconsciously, every time I touch her, my hand goes there. And she's like, no, don't do that. No, don't do that. So she doesn't want to talk to me about anything that hurts anymore. so, what I generally try to do then is, okay, I check my thought and I go right back to the start. Let's stay in the history. Let's look at any kind of metabolic issues that might be contributory. Let's get that in the history. Let's look at any pain neuroscience, yellow flag aspects that we might want to consider there as well. Any past health history issues that we might want to consider. And then as we start our physical exam, staying big neuro, start at the neck. So if she has pain with a specific movement, let's say it was, elevation and moving the arm back into extension with, something that looks like this, then I'll have her go into that position and I'll, move behind her and do traction at the neck and see if the range of motion changes. Being intellectually honest that I'm also providing a lot of afferent input here, and it could be possibly a gate control issue that's just happening here. Or there's a whole lot more stuff going on at the intersection at the I think it's lamina 2 and the dorsal horn, where that secondary neuron traveling north is going to be occupied with other thoughts as well, so to speak, coming from the periphery. But I'll start with that. And then if I get buy-in, the range of motion improves or they report less pain, then I'll stay right there for a moment and I'll do several pulsed tractions. And then I might even have them do something that, I start to move towards an intervention that they can do at home. So typically my go-to is going to be McKenzie because it's easiest for them to reproduce at home, not because it's necessarily more effective. And my second intervention would be something that looks like static openers, just trying to open the neural foramen there if we got input there. And I always check if they get benefit from any one of these places that I do intervention. I say, what percentage would you say the improvement is there? And if they say anything, and this is just default over the years, it's just something I've come to. If they say anything less than 30%, I don't get terribly interested in it. If they say 30% or more, I start to get a little bit intrigued by that particular interface and to double down on it. And that's when I'll start to do the other interventions. Okay? So then I just kind of table that information. Now I have them go back and repeat their index test and see how much better it is. And I'll make a little note of that. And then we move from that interface to, in this case, of your case that you're bringing up, if we move to peripheral motor neurology or peripheral mixed nerves, that's typically going to be the radial, the median, and the ulnar nerve that we're going to be considering down in this particular area. And at that area, for those, I would do the upper limb neural tension tests, and I'm biased towards Michael Shacklock's approach in that from his neurodynamics. I think they're the most rigorously studied in how in your handling and setting those up. So I try to, as much as possible, poorly emulate Michael's work there. And at each one of those interfaces, the quickest way that I would do it, to get back to your original question, how do you go downstream and check it? With the traction, we've taken care of basically the radial nerve down to this point. So I would go into radial nerve in the axilla and go to the triangular interval and gather it up and do a DTM investigation there, just creating a different mechanical interface there while she does the index movement. Now, does that change it? No. How about if we challenge or change the axillary nerve space there? How about if we go further distal down around the corner to the radial groove area, or right underneath the tendon for the deltoid there, and repeat the same test. Continuing the radial nerve downstream, I'll go right over the extensor wad and create some space right there, just proximal and distal to the joint itself, to see if we've got any changes there. And then finally downstream over the radial aspect of the wrist, over the path of the nerve there. Now I've kind of gotten my radial nerve investigated, and I could do the same thing along the, for right here, we could get the ulnar and median neurology in this particular area in the brachium. And then going downstream beyond the elbow, or at the elbow, we've got what is it? We got Struthers and I'm blanking on the name at present, but just pre and post on the medial aspect of the elbow, we've got our fibrous tunnels where the ulnar nerve is prone to entrapment, and then prone to entrapment down around the tunnel of Guillain. So I'll do the same thing and do DTM on all of those while she's repeating that. At each place, does that make it better, worse, or same? If it's better, what percentage better? Boom, boom, boom. If we get something more than 30% and I see something there, I'm going to double down on it. Maybe we've got a little something going on here or something going on here. And I'm going to do something that looks like a combined floss DTM thing, and then repeat the index. Okay, so now we've got, let's say, just for sake of numbers, 60% improvement. Okay, 60% improvement in just about any office is pretty good within treatment changes. But then I go downstream and check the local neurology, but I would work from center out on those patients to most directly answer your question. It's very easy to start out and just go right, just think about, okay, she's hurting right here. Let's go to the median nerve or to the radial nerve, and let's play with that particular area. And I might do that sometime. When I do that, I'm just very quickly often trying to delineate meat versus nerve and get the patient's attention. Because you guys know that when you do that, the pain gets a lot better. There's this double take that the patient does, and they're like, wait, what did you just do? And then at that point, you kind of have their belief system at a tipping point. And that gives you power. You can behave with that in any way that you want. You can treat that palliatively, locally, and some would say that's good work. It'll keep coming back frequently, and you can keep having the patient come back frequently. And that's a pretty good practice model. And you can do that. The patient will think you're cool because nobody else is doing this. But are you really addressing the problem? Are you really getting to the pith of the matter of what's causing all of that? And if we go back to your patient with the elbow issue, I mean, every throwing athlete that I'm going to work on with medial elbow pain, I'm going to look at through a DNS lens and through a regional interdependence lens. Because if they aren't extending well in their thoracic spine, if they're your volleyballer and they're doing an overhead smash kind of movement, or a pitcher doing the same movement, if they don't have, going back to our algebra, they don't have adequate mobility in the thoracic spine for extension and rotation, if they don't have adequate glide of the scapula on the rib cage, if they don't have adequate stabilization of the scapula on the rib cage when they try to affect those movements, and or the glenohumeral joint doesn't have enough mobility, then the body in that ask is going to ask for more out of that elbow, and that's going to stretch those ligaments in that area and potentially cause that issue. What I would love to see is a prospective trial on pitchers where we apply this kind of approach and we identify something like that in pitchers and see if it results prospectively in less Tommy John surgery or something of that sort. That'd be a tough design, and it would be very difficult to get enough ends in that cohort to get any kind of statistical significance either. So we're well represented here today by the Upper Midwest. Our Dakota boys are here. Eric, I haven't heard from you. Are you still there, or are you just turning this on and wandering around the kitchen aimlessly?
I'm listening. It's probably more listening in. It's probably more than anything else at this point. But
I hear you. What's on the smoker right now?
Nothing. We actually rebuilt our fence in our back patio, and I haven't. I've been spending so much time doing that I haven't been able to do a whole lot of anything else. So,
all right.
The one thing I got to do was go visit Mike Rintal in San Diego. About
Sweet.
2 weeks ago for that course. And
who did you have down there helping out? Was it Michael Troop?
Peter Bittner.
Oh, that I would have liked to have been in on that. His some of his grad school papers were very fascinating.
It was.
What'd you learn?
Well, he covered the viscerosomatic dysfunctions is what the course was on. So it was a lot of visceral manipulation. Thad was there.
Far out.
He was there. Robert Lardner was taking the course. Just a plethora of people taking the course, and so it was a good course to be in with the participants as well as the instructor. I don't think the course had been taught for 5 years in the U.S. since before the pandemic, so I was kind of waiting for it.
Did Charlie make that one?
He did not.
Charlie Weingroff?
He did not.
Yeah, I remember he pinged me a while back that he was really excited about one of the courses that Michael had going on, and we dialogued back and forth about it a bit. But yeah, I think he was mostly talking about the some of what Michael's offering now of live stream access to some of those courses. Did they live stream it as well?
Well, he's been doing kind of stemmed out of the pandemic where they kind of started doing a little bit more of a tutorial idea. When and it allows the instructors to cover a very narrow topic that they're interested in.
Right.
So like Peter Bittner did his on trigger point chains in and around the head and the eyes for headache symptoms. So it was by the time I got to that point of the weekend and I sat and watched it live, I was just so brain fried. I just went, okay, I'm going to have to go back and watch this. So, as I know, I've got a few people that I looked at and I'm like, okay, that's some people that I know would benefit from it. And not going so far off of what I learned at the NCA courses and what I've learned from Yugo, is that type of stuff, but also thinking about where these trigger points are in relationship to where some of the superficial nerves end up piercing through the layers of fascia. So there's a lot of discussion of fascia and everything. So I know, like in the course, one of the things we kind of covered was, the people that don't have a solution for hiatal hernias. or how important stomach issues are. Myself, I was partnered with Thad, and I had kind of been having some persistent left side lower back pain, and so he was doing some fascial manipulation or fascial visceral manipulation to during the course to the descending colon and to the sigmoid colon area, and my back pain has been I'd probably say reduced by 90% since that time, and that's been 2 weeks. So it kind of gave me that. If we go back out to all the Merrick chart, he kind of gets into some of that stuff a little bit more, and then you realize, yeah, there's a lot more to it. Makes you realize there's a lot more to it. He was showing some of the case studies he had and some of the research they've been doing on diaphragmatic breathing and the instance of things like GERD and hiatal hernias, and just all of how, if you're not doing the diaphragmatic breathing, that you're going to end up having less motility through the internal organs, and how much the kidneys will move and everything else. So it was interesting that way, but then also looking at just the anatomy of the ligaments that we don't always think about, whether it's the mesentery or the ligaments in and around the heart that are connecting the heart to the posterior thoracic wall, and how that can affect some of the biomechanics and movement patterns that people have in the cervical spine. So
Yeah, those are high level osteopathic perspectives that Justin's done a lot of. Justin Dean's done a lot of work on, as you know. The stuff you're talking about with hiatal hernia and GERD, that's Peter's papers from grad school that I'm aware of. I remember getting in touch with Alana years back when that was like mentioned in passing at a course, and I was like, "Hey, Alana, do you have any actual research that's been done to investigate this?" And she handed me off to Peter's papers.
So
the MRI that they showed of doing of the difference in the diaphragm position and the esophageal position at the sphincter there, the cardiac sphincter, based on different positions of thoracopelvic canister stacking, as Evan Osar refers to it and such.
The interesting thing is he had endoscopic cameras to show all of this stuff within the coursework, to show here's the lower esophageal sphincter at the diaphragm, and then also showing pressure mapping through the entire esophagus to show what was happening in those scenarios. So it was really it was interesting to see in that aspect, and I've had some quality results with some of the people that I've been doing some of the visceral manipulation on with that as an adjunct to the other stuff that we're doing in all those scenarios as well. But it was just kind of one of those, I'd waited a while to take it, and I went, it's coming. I think I'm going to go take it. So I had 3 days of class and a half a day in Solana Beach and an hour at the beach. So
right on. And you got to hang out with Thad, so that means you probably drank heavily.
I did. Well, I just really saw him during the course. I got to hang out with Mike and Peter and a number of others, Robert and a number of others at a Japanese steakhouse. And the first day I was there, I traditionally go to Pizza Port, which is a brewery and pizza place. And then then I walked over to another brewery, and then we went to the winery and met up with everybody at the winery. So
far out.
Solana Beach is a nice little community to get to, and plan on going back in January.
Yeah. All right. Yeah, it's a good time of year for you guys up in that part of the world to get out and head south for a wee bit.
So.
Yeah. Anybody? Any of you guys planning on going to the neurodynamics conference down in Dallas in November. Yeah, that looks like it's going to be a pretty good showing. Shacklock, of course, is there, but Mike Leahy's going to be there. Brett Winchester, Annie O'Connor, and Jeff Bove's coming in. So,
mine's yet to be determined, but that's all a work schedule thing. So
yeah.
No.
Well, okay, kids, we are approaching 1 hour now of us being in here, and trying to be a little more consistent with these and trying to keep them in an hour so folks don't they can make plans around their weekend time and their families and stuff. Try not to get you guys in trouble, because I know you all got kids who are hankering to go and do something more fun than watch daddy sit in a chair and look at the computer. So we are going to head out to we're going to head out and see if we can find some chanterelles in the area woods. And I will post this is being recorded, so I'll post the recording both on my YouTube page, and I'll link to that on the community page for NCA. Anybody have any parting shots? All right. Nice to see you all, and I'll see you same bat time, same bat channel next week.
Have a great weekend, everybody.
Take care.
Yeah.